Thanks everyone for coming. We're going to get started with today's lecture. We're very fortunate to have Dr. Bill O'Neill here with us. So Dr. O'Neill has now been at Henry Ford for a few years, but we were lucky enough to recruit him back up north from the University of Miami. He's a legend really in the cardiology space, so some of you who not being cardiology may not be aware, although you probably are, but he's really a pioneer in interventional cardiology, from angioplasty for acute MI, but more recently into structural heart disease, which we basically are percutaneous approaches to large-scale heart problems, valves, holes, and other stuff. So the legend is here to update us about what's going on now. The Center for Structural Heart Disease here at Henry Ford has really exploded since he came on board, and they are leaders nationally really in innovating new and interesting ways to help patients minimally invasively or percutaneously, really being featured at many of the national meetings and with publications and leading the space. So he's going to give us an update on innovations in structural heart disease. Dr. O'Neill.
Dave, thank you very much for the kind update. It's kind of a daunting task to talk to this group because there's nurses, physicians, advanced practice folk, residents of all sorts of disciplines. So, you're not going to get an erudite, intense lecture on any one particular topic. I want to give you kind of a little bit of an overview about what we're doing in structural heart disease and kind of a little glimpse into the past, and then how we kind of decide on what problems we're going to be treating and solving in the future. So this is the team here, a fantastic group that is now working with us. Adam Greenbaum, to our right there, just recently left Emory. We replaced him with Dr. Frizzoli, who's an excellent new addition to our staff. But like transplant, it's a multidisciplinary team. And I think that one of the strengths of Henry Ford as an institution is that for years, people here have been collaborating. I'm one of the old dinosaurs. When I started roaming the land, I would see a patient, tell them what they needed to do it, and then follow them. And I didn't really have to ask anybody for permission. Now it's like you've got to talk to 5 different people and get all sorts of, and actually that's the way the medicine is going. It's gotten too complex for any one particular person to be able to have all the skill sets that's required to treat these very complex patients. And that's the strength of Henry Ford. I think we can offer care for the complexity of the kind of patients that are going to be happening in the future. So as a brief overview, structural heart disease, what are we talking about? We're talking about valvular heart disease and other structures. The aortic valve, our main treatment is called transcatheter aortic valve replacement, or TAVR. This is a method of fixing patients with severe aortic stenosis. The second valve is the mitral valve, and there's a variety of new treatments to fix these non-surgically. We also have a procedure called left atrial appendage occlusion, which is implantation of a device in the left atrial appendage to prevent clots from forming inside the heart and prevent this from embolization, so that in patients with atrial fibrillation, you can avoid the need for anticoagulant therapy. And then the future is going to be replacement of the mitral valve, and we're right at the cutting edge of that right now. Well, why would we want to do this? We've got a fantastic surgical group. Surgical valve replacement, coronary bypass surgery has really become a dominant therapy. The history, the outcomes have been known for 40 or 50 years. So what would make you want to do these kinds of procedures? And the reason is that our patient population is aging. When you talk to a 50-year-old man about having a sternotomy and open heart surgery, okay, it's a big deal. They recover in 2 to 4 weeks or back to work in a month. When you talk to a 90-year-old about that, there's an entirely different ballgame. And most of the patients that we're dealing with are in the geriatric population, and they really, really are desperately avoiding to have these major operations because of the comorbidities and the time for recuperation. So they're all looking for non-surgical alternatives. So this is basically a consumer-driven approach to try to deal with these elderly patients. you can see that our volume, and kind of if you build it, they will come, and you can see that our volume has dramatically increased over the last 5 years. The mainstay of our is transcatheter aortic valve replacement, or TAVRs. We're doing more and more mitral procedures, and we're doing more of these Watchman procedures. So the procedures really are booming in the institution. We're now one of probably the fifth largest program in the country for doing these kinds of combined interventions. The other thing that's really interesting is that we have this annuity. It's called the baby boomers. And the reason why that's an annuity is because all the baby boomers are now starting to retire. 10,000 people a year are retiring in America right now. And those patients are all going to be developing some form of heart disease, and probably one of the dominant forms of heart disease is going to be aortic stenosis. So when you take a look at the natural history of aortic stenosis, patients start becoming symptomatic at 65 or 70, and so there's going to be a huge increase in the numbers of patients that are going to require this form of therapy. And you can see that this has basically been a very viable thing for our institution. The growth of the TAVR and the structured heart program has generated an enormous amount of revenue. It's not a coincidence that the hospital's been making a lot of money over the last 4 years, and a lot of that has been driven by this approach. And we're very cognizant of that. We're not a for-profit venture, but we in our program are really trying to help the institution to become economically profitable, and that has a magnitude of spillover to everybody else in the institution. I've worked in hospitals that are making money, in hospitals that are losing money. And trust me, it's much more fun to work in a hospital that makes money. Because in a hospital that's losing money, you don't get the resources. The first thing the hospitals do is they try to cut nursing care, because that's the biggest budget item. And so the nurse-to-patient ratio shifts. And then replacing staff, building new equipment, just really being able to optimally care for your patients is really dramatically impeded on. So I feel that one of our responsibilities is to be financially cognizant of the stuff that we do to make sure that whatever we're doing in some form or other is revenue producing to help the institution. And these are the gross patient revenue. And the case mix index, again, for those of you that aren't familiar with this is something that Medicare uses to pay the hospital based on the acuity of care. So if you have a low case index, the patient is kind of uncomplicated. If you have a higher patient case mix index, then the Medicare pays more money. And these numbers are just very small. A 0.01 increase in case mix index in most institutions is something between $1 and $5 million for every 100th of an increase. And over the last 5 years, there's been an enormous increase in the case mix index in this institution. Another reason why we become financially profitable. So it all kind of comes together. What's happening at Henry Ford is that we're recruiting, or we're treating a much more complicated case mix. We have a huge increase in the number of out-of-network, out-of-hospital referrals, and we have to be able to take care of these kind of complex patients, and that's kind of what the approach that we've been trying to take. Again, strategically, we're looking at TAVR programs. When I did the first TAVR in the country at Beaumont in 2005. At that time, there was one hospital, Beaumont, that was doing TAVRs. In 2007, when the program started, there were three. There was Beaumont, Henry Ford, and University of Michigan. Now there's over 20 TAVR programs as this procedure has become more of a commodity. And so we have to be very cognizant of that. We want to be incredibly competitive in terms of providing a very user-friendly program that's friendly for the patients, that's friendly for the referring physicians, and most importantly is high quality. And we can do all of that. We've demonstrated that our length of stay, our mortality is substantially better than the national average and the best in the state, basically. And as a result of that, the program is going to continue to improve. But we are now going to be partnering with our other, and we're looking basically to really collaborate hand in hand with the strategic vision that Mr. Lassiter has had for the institution, dividing up into three sort of main structural areas. We're working with our partners in Macomb right now, and we're getting a lot of patients transferred here for TAVR. At some point in the future, there have to be a program established in Macomb, and then with our new partners in Jackson. And Jackson, we think, is going to be a huge growth opportunity for us as we start developing these interventional procedures in the outlying institutions. So I wanted to really review at the start why we're doing what we're doing, not from a patient care standpoint, but from a strategic standpoint, to really align with the institution, to try to tell you, and all of us are doing that because if we can be cognizant of the profit loss of the procedures that we do, optimize the length of stay, optimize the management of these patients, then the institution does better. And when an institution does better, we all do better. And that's really one of the main things that we do at the onset. So why are we doing what we're doing? So this is FDR. It was 4 months before he died. He was at Yalta with Winston Churchill and Joseph Stalin. And while he was negotiating the fate of Eastern Europe and exactly where the world was going to be after World War II, his blood pressure was 230 over 130, and he was in pulmonary edema. And so you imagine that this guy is like on death's door, and everybody says that Stalin got the best of him, and probably a lot of what happened in the last part of the 20th century was related to the illness that Roosevelt had, and his main problem was malignant hypertension. The other thing is that he was 62 at that time, and Winston Churchill was 65. So look at the pictures here. So this is, they say that 60 is the new 80. Well, I think that's changed a lot. And what's happened is that there was an epidemic of atherosclerosis in America between 1950 and 2000. Acute coronary heart disease, acute myocardial infarction, and as a result of this whole industry sort of developed. So we start doing heart caths, we start doing open heart surgery, we start doing angioplasty, a $40 to $50 billion enterprise a year in the United States, all built on one disease, which was acute atherosclerosis, right? And we've done an incredible job. One of the great success stories of modern American medical medicine has been how well we've really treated this epidemic of acute atherosclerosis. It all hasn't been angioplasty and bypass. There's been a lot of fundamental understandings of what actually causes acute infarcts and atherosclerosis. And so smoking cessation, control of blood pressure, control of cholesterol has dramatically ameliorated this. This is now the patient that we're treating. So now 100 is the new 80 and so this is kind of what our patients look like now. These are our patients. Now imagine when I was just starting in practice, if you had told me that I was going to be doing a heart cath on a 90-year-old, you would have said, you're crazy. There's no way you're going to do a heart cath on a 90-year-old. But in fact, the patient, our population is aging in a much more healthy fashion. Control of blood pressure, control of smoking, control of cholesterol has really allowed a very large proportion of people in this country to live much longer. One of the largest growing patient populations are actually women over the age of 80. And so again, for the health care of our community, we have to try to figure out what are the diseases of the future that are going to be affecting us, and how are we going to be prepared to deal with that. And that's really the reason that around 2002, I realized that we would have to start turning our attention from coronary artery disease to valvular heart disease, because valvular heart disease was going to become much more prevalent as the patient population aged. And you can see, in fact, that one of the big success stories that's happened in the United States is that over about a 20-year period of time, the longevity of America has increased about 10 years because the time from onset of heart disease shifted over 10 years. And so we're going to now start to deal with many, many more patients that are in their late 80s and 90s even. And so doing heart caths on 90-year-olds is actually pretty routine right now. So again, we're looking forward to see what are the diseases in cardiovascular medicine that we're going to need to be dealing with. And what we've realized is that there's three things that are going to be happening that are unrelated to coronary artery disease. One is aortic stenosis, the second is mitral valve disease, and the third is atrial fibrillation. And those are very common diseases now that are going to be present in the American patient population, and that's what we're kind of looking forward to try to figure out how are we going to be treating those patients. So that's kind of an introduction into why we're doing what we're doing and why is it this population of patients that we're really treating. This is the disease that we're dealing with primarily with the aortic valve. This is a tri-leaflet aortic valve that's present functioning normally. It's an incredibly bioengineered area that really works beautifully until you get to about the age of 70 or 80. And then, again, you get these plaques that are present here, these nodules of calcium that close the aortic orifice and cause aortic stenosis. There is about 3% of the population is born with a bicuspid aortic valve. This is the most common congenital defect that people are born with. This starts affecting people. It causes the valve to age prematurely, and patients in their 60s and early 70s develop this. Rheumatic valvular disease is very uncommon now in America. In third world populations, it's actually very prevalent. But this is really primarily the disease that we're dealing with, degenerative, calcific, senile aortic stenosis. This graph is kind of hard to see, but of the diseases that would develop, symptomatic aortic stenosis is really one of the most lethal. If you take a look at what happens to patients when they start, there's a latent period where they have a murmur and they're not very symptomatic. But then once people develop symptoms, within about a year, they're going to have something that's going to cause them to either have surgery or to die. And so this is an incredibly lethal disease left untreated. So in one sense, it's actually easy to treat because there's really no choice. Once patients become symptomatic, if they don't have something done, they're going to be hospitalized or they're going to expire. And so this is from the Mayo Clinic. If you take a look at the natural history of patients prior to open heart surgery, when they would start presenting with symptoms, and you could see that basically all of the patients were dead. This is probably more malignant than most of the malignant tumors that we deal with, because at 1 year, 50% of the patients are dead. So it's a 50% mortality within a year and almost a 90% within 2 years. Again, from the Mayo Clinic, when they first started looking at this natural history, they looked at surgical valve replacement. And so they looked at 50 patients who were surgical candidates, but half of those patients declined. And again, you can see that the vast majority of these patients were dead very promptly after they started developing symptoms. There's never been a randomized trial of medical therapy versus surgical valve replacement. It was felt to be unethical because the disease was so severe and the surgical therapy was so much better. So it's really become kind of mainstay therapy. It's a guideline 1A recommendation to do surgical valve replacements in patients that are appropriate candidates for surgery because the disease is so rapidly progressive. And again, I tell you this not necessarily to make you experts in management, but in case you have patients or family members, because it's a very common condition. Our philosophy has been to sort of follow the patients closely until they become symptomatic. There's no harm with waiting until they become symptomatic, but once they become symptomatic, you have to rapidly address and rapidly treat these patients. So how did I start in all this? In 1988, I did the first balloon aortic valvuloplasty in the Northeast. Myself and Dr. Igor Palacio, Mass General, were the first two in the country to do it. And we had no way of treating these patients that were symptomatic, completely inoperable. And we went in and put a balloon, and stretched the valve. And we got some really nice results, but there was really long-term no improvement because the valve within about 3 months would completely restenose. But it looked like, okay, so if there was some way of fixing the valve, this might work very well and you might be able to do something non-surgical. It's just that there wasn't anything available. Dr. Anderson thought about the same thing that we were thinking, and then he said, well, why don't you just sew a porcine valve on a stent? And this is sort of like the original prototype. Now, if you say this, you're going to put this in a human being, it's really, really unlikely. But in fact, the Anderson patent was the first patent. And just out of interest for some of you young entrepreneurs, ultimately a company called Edwards bought this patent. There was another company, Medtronic, that had a valve that was very similar to this, and they had a patent dispute. And Edwards won $1 billion judgment against Medtronic with about $100 million a year royalty because they infringed on the Anderson patent. So just out of interest for all of you who are inventors. So this is the first patient that we treated here in North America, Mr. Giangrandi. I met him in 2003. He was in our intensive care unit. He had 2 previous open heart operations, had an ejection fraction of about 25%, had severe aortic stenosis, was in the hospital with refractory heart failure. And basically, he was really depressed, and I met him. And I said, well, I think we can probably fix your coronary disease because he had severe stenosis. And I did a valvuloplasty at the same time, and he did dramatically better for about 3 months. And then the valve started to restenose. And so he was the first one in North America to have a transcatheter valve. The way that that's done is that we did a catheter, a transeptal approach, put a valve in across the mitral valve, and then deploy it in the aortic, and this is what it looked like afterwards. The patient lived for 6.5 years, and he's just dramatically better. So it was like, you know, with Jerry Maguire, you had me at hello, you had me at Mr. Giangrandi, because I knew I didn't need a p-value, I didn't need a whole series. I knew that this was absolutely a life-changing procedure based on the first patient that we treated. And so it's been a long process between 2005 and 2011. Multiple studies were done. This was the first randomized trial that was called Partner 1. It was a randomized trial of standard therapy compared to transcatheter valve replacement. And you can see that the numbers needed to treat is to save a life is 3.4. Just to give you some of the cardiologists that are here, the number needed to treat for emergency angioplasty therapy of acute infarction, that's a mainstay, is 14. You need to treat 14 acute MIs to save 1 life. You need to treat 3 patients with aortic stenosis to save a life. That's how potent this intervention is. This is the only randomized trial that's ever been done, and only one that will be done. I was at the University of Miami when we were doing this. We had 17 patients that were in this trial. 9 of the patients were randomized to standard therapy and 8 had TAVR. At the end of a year, all 8 of our patients were alive with a TAVR, and only 1 of the 9 patients that were in the medical therapy group were alive at a year. So again, just within our own little microcosm, we knew how potent this intervention was. So it's really one of the most potent interventions that we have in modern medicine. And it really now is proven that it's been a true life-saving treatment. Now, more recently, we've been looking at a much lower surgical risk. So those patients initially in Partner 1 were completely inoperable. More recently, we've actually finished a study in the low-risk population of patients who are in their early 70s, and that study is going to be presented at the ACC in March. But based on the data that we see right now, we think that the SAPIEN valve, which is the valve that we've been using primarily at our institution, is going to be better than surgery for intermediate risk and low risk patients. So it really has become mainstay therapy. And with the unknown still, the valve, again, the first one we did was in 2005. So we've only got about a 12-year track record on durability. And so we're not totally advocating doing this on younger patients because we still don't know how durable the valve is going to be. With a surgical bioprosthetic valve, they last for 10 to 12 years. And we think that this valve will be as durable, but we still simply don't know yet. And we're going to be following the patients. So for this low-risk trial that we're currently doing, we're actually following the patients for 10 years. So there will be some systematic analysis over a period of time to see how good and how durable those valves are. So this is now the youngest patient. So I've come full circle, because I remember that first picture I showed of Mr. Giangrande. I had brown hair and he had white hair. Now I've got the white hair and he's got the brown hair. So that's kind of how things have shifted over time. And this is a 32-year-old hockey coach and a soccer coach, and people know him. He's been in the paper and stuff. But he had a surgical valve replacement at age 20 because of a damaged valve. At 32, the bioprosthetic valve was failing, and he was told that he needed heart surgery, but they wanted to put in a mechanical valve, which would have necessitated him having Coumadin therapy for the rest of his life. He was a soccer coach. He wanted to play soccer actively, and knew he couldn't do it with anticoagulants, so he made this decision. Fortunately, we were able to persuade the insurance company to do this. He was in the hospital for less than 24 hours. We did the procedure around 10 o'clock on the day of the procedure, and by 8 o'clock the next morning, he was ready to go home. And he went back to play soccer, a week later. So it really kind of demonstrates the ability of these non-surgical techniques to dramatically improve the quality of life for the patients, but also the length of stay in the hospital. And again, for these elderly patients with multiple comorbidities, the hospitals are really dangerous places, and you want to try to get them out really rapidly. Currently, the patients are in the hospital for an average of about 2 days right now, and they really are doing dramatically better with this new surgical approach. While in the process of doing this, one of the things that our institution has gotten attention for is other ways of getting the valves in. Normally we put the valves through the femoral artery. Some patients just have vessels that are too small or calcified to allow this. With Robert Letterman from the NIH and Adam Greenbaum, we developed this technique for crossing from the Vena Cava into the abdominal aorta, and then being able to deliver the valve that way. The technique is we use this cautery device. We go across the aorta. We put the sheath from the IVC through the retroperitoneal space, and then we close it with a patent ductus arteriosus occluder so that patients don't bleed. And this is really pretty dramatic. We were the first in the world to do it. We've now led, there have been over 200 institutions around the world that are trying to use this technique. And so it's one of other approaches. So as we're doing these procedures, we've come into problems. The approach has been, okay, you have a patient that's presented with a disease, you think you have a therapy. If you don't have a therapy, how can you get a therapy? And that's kind of the way that we've developed a lot of the innovations that we're doing. Switching over to the mitral valve, so I told you that the mitral valve is the other major left-sided valve that starts having problems as patients age. Again, very similar to aortic stenosis, we first started doing a balloon mitral valvuloplasty. This is an in-away balloon that goes across the stenotic mitral valve. It starts to expand, and then the valve opens and closes. With rheumatic disease, mitral stenosis, the mitral leaflets, the commissures close, and you can rapidly do a commissurotomy, which is actually replicates the surgical technique. Originally, the first operation, the valvular operation, was done in the early 50s, where the surgeons would go in and open up the left atrial, and put their fingers across the valve and do what's called a closed commissurotomy. That's sort of how the technique first developed, and this is basically trying to replicate that. It's a very good procedure for mitral stenosis, but we don't see very much mitral stenosis in the U.S. anymore. At the advent of penicillin has eliminated or decreased the incidence of rheumatic valvular disease in the U.S. It's still present in third world countries, and we do see immigrants that come in with mitral stenosis, but very uncommon. But it was the substrate that showed that we could safely work on the mitral valve with a non-surgical technique. So now, cycle forward 2011, I meet this lady, 90 years old. She's got pulmonary hypertension. She's got severe lung disease, and she has severe calcium of her mitral leaflets and mitral stenosis. So again, we're confronted with our problem. Is there any way of trying to treat this person? Well, we went ahead and I was hoping, let's go back. unfortunately, these slides don't show, but these slides don't play. But what I did is this is the heavily calcified mitral valve, and we put a balloon across, and we open up the valve. And very similar to aortic stenosis, the valve improved, the patient got quite a bit better, but then 3 months later, started becoming symptomatic again. And so we were the first in the world with Myra Guerrero to do this. We put a sapien valve. This is an aortic valve, which was actually put into the mitral position. Remember, I was used to doing this before with antegrade. We would advance this valve through the mitral and up into the aorta. But for this, we're just leaving the valve in the mitral space. And we were able to successfully open up the valve and have an improvement. But unfortunately, we have outflow obstruction. So this is before the valve was implanted, and this is after. She developed a severe gradient and expired from this. And so we were concerned that this was going to be a huge problem. And so we developed a technique called alcohol septal ablation. And what we actually have a catheter and putting alcohol into the first septal perforator to ablate the upper part of the septum. And with this therapy, the gradient completely eliminated. So now we've developed this procedure, and we were the first in the world to do this successfully. And now this is being done kind of around the country. But the thing that really led us to take pause was we really didn't know that this was going to happen. We'd heard about surgical reports, but we were not certain. And so we then realized that if we're going to be doing these complex interventions, that we're going to have much better imaging. And so with Dr. Didi Wang, who's an absolute whiz, and with our research institute, we've now developed these 3D modeling where we can do these amazing images and looking at 3D to see how these valves would fit together, whether or not this is an example of a patient that's had an aortic TAVR valve, and then this is a mitral valve. And you can see how you have to make sure that these areas interact properly, that they're going to fit, and they're actually not going to impinge on each other. And with the imaging techniques that we've had in the past, it was simply impossible to be able to do that. And now we're doing these 3D models and these CT reconstructions on a routine basis, and we're really probably leading the world in doing this for these complex structural interventions right now. So again, what we're trying to do is we're trying to improve the safety and durability and predictability. And the one wonderful thing about these procedures now is that we can, ahead of time, we can model, we can image, and we can say, okay, can we do this? What kind of valve are we going to put in? What size of valve? What is the location? And what is the likelihood that some sort of complication will occur? So this is really kind of a really wonderful approach to improve the predictability and the safety of these procedures. The mitral valve is an entirely different being than the aortic valve. The aortic valve is sort of a circle and 3 leaflets. The mitral valve has lots of differences. It's much larger. It's a bicuspid valve. There's an anterior and a posterior leaflet. And the valve can have ways of malfunctioning. Either the leaflets could have trouble, the annulus could have trouble opposing, or the cords could have trouble. And so it's a much more complicated structure, and it's going to be much harder to develop one solution for this valve, and there are going to be multiple that are going to be required. And again, we're thinking ahead to try to figure out what are the solutions that are going to be required. We're looking initially at our surgical colleagues. Our surgical colleagues have put in these bands, these surgical rings around the mitral annulus, because annular dilatation is one of the big causes of mitral regurgitation. And so there are ways, and we'll talk briefly about that, of fixing it. Also, there are leaflet edge-to-edge repairs that surgeons have done, and then valve replacement. So currently in the United States, the one procedure that's available is the Mitral Clip. And this is a clip that goes and clips together the anterior and posterior leaflet of the mitral valve to kind of create a double orifice. This is based off a surgical technique called the Alfieri stitch. It works, it's very successful, and we're doing more and more of these cases, and we'll probably do over 100 of these kind of clip procedures this year at this institution. And there's a variety of other approaches. There's a technique for putting in a band percutaneously on the posterior mitral annulus and cinching this together. This is called Cardioband. We've done one of these procedures, and that looks like it's going to be very promising. And ultimately, transcatheter valve replacement. So the way that you can get these new valves in is either going in from the apex, and that's where most of the mitral valves that are going to be done, and we've done here, I think close to 15 of those. The other way of approaching it is transeptal, and I showed you with the original mitral valve sapient position that we did this, and this is probably going to be the ultimate solution. And so we're looking to find valves that will be able to go across the transeptal path. The transapical approach is kind of a relatively morbid procedure, and the patients really, if they have severe lung disease or severe obesity, it's very difficult for them to tolerate that thoracotomy. So I think at the end of the day, most of these patients are going to be treated with this transeptal approach. These are some of the valves that are out there. There's no one valve that's approved. There's probably going to be at least another 5 years before any of these valves are become approved in the United States. This is, I hope this plays. It's not playing. So this was going to show you basically the way that we're doing this new sapient system. Just very briefly to describe it, what it does is there's a really novel device that comes across the intraatrial septum, and we put this cinch around the valve, and then a sapient valve is delivered. This is a transeptal approach. We're going to be doing the first patient here in Michigan next week, and I think that this is going to be a big future for treatment of mitral valve disease. So along with my colleague, Dr. Frizzoli and Dr. Ang, we have this very elaborate group now of therapies that we're offering for our patients with mitral regurgitation. Either we can put clips in, and there's a new clip that's called the Pascal to hold the valve leaflets in place. We have an annulus solution to close the annulus, and then we have a new mitral replacement. All of this is really predicated on the advanced imaging that we have to try to figure out what's the problem with the valve and can we offer anything for fixing it. I want to, excuse me, I want to conclude this afternoon by just very briefly telling you, again, another thing that this institution that we have to have an enormous amount of pride in, and this is in the management of acute myocardial infarction and cardiogenic shock. This is different than structural heart disease, but it is sort of integrated. And this disease is probably the most lethal that we face in cardiovascular medicine. So if a patient comes into the hospital with a massive infarct and their blood pressure is below 90, they're developing shock. Within 10 hours of symptom onset, 50% of the patients are going to be dead. Within a week, 90% of these patients are going to be dead. And so this is really the most lethal emergency disease that we face in cardiovascular medicine. I did the first trial of acute angioplasty in 1985 at the University of Michigan, and I would guess probably 3/4 of you guys weren't even born then. But this was the first approach of trying to improve the outcome for these patients. Mortality was 80% if they were untreated, and it was 50%. So we significantly improved the survival for these patients, and this is a study that was done 30 years ago. More recently, last year, another study in Germany, a large study of angioplasty, and again, with angioplasty and balloon pump, a 50% survival. So in 30 years, we haven't really made any inroads on this incredibly lethal disease. And so we've been looking, I really haven't seen anything in the last 15 or 20 years to give me any enthusiasm, but in the last 2 years, there's just a huge new advance that I wanted to tell you a little bit about. There's a catheter called Impella catheter made by a company called Abiomed. I'm a consultant to that company for full disclosure. But this device is a novel device that goes in from the femoral artery. It sits in the ventricle. It pumps blood out. It pulls blood out from the ventricle and forcefully inserts it into the aorta. As a result of that, it increases the forward cardiac power and increases the mean arterial pressure. So this is ideally suited for somebody that's in cardiogenic shock. If you can take a look, and in addition, it has very beneficial effects. It decreases left ventricular end diastolic pressure and decreases left ventricular end diastolic volume. And by doing so, it helps the mechanics of the heart, decreases microvascular resistance, increases coronary perfusion. So you increase oxygen supply and decrease oxygen demand. So it's an absolute perfect physiologic tool for being able to rest the ventricle and support the heart in patients with severe LV dysfunction and cardiogenic shock. And by the way, I think this is something for the heart transplant group that is going to be incredibly important, because as we survive more and more of these patients, there are going to be some of those that are going to become eligible for either LVADs or heart transplant. So in April of 2016, we got together with all the health systems here in Southeast Michigan, Providence, Beaumont, St. Joseph Mercy, and the DMC, and we realized that this disease there's really nothing competitive. We're not competing. A person from Pontiac is not going to drive down to Detroit to be treated for their cardiogenic shock. And so the doctors kind of felt that there wasn't going to be any competition, but collaboration. And so we all got together and decided to treat the patients the same way, with very rapid identification of the patient, very rapid insertion of the impella, and then do emergency angioplasty. And in fact, we found that in the first 50 patients, there was a 76% survival. So this is a dramatic improvement in survival compared to the traditional group. As a result of that, there's been an enormous amount of interest around the country in developing similar kinds of programs. These are the big trials that have been recently done, the contemporaneous trials, and basically showed that there's really only a 50% survival if the patients are treated with the traditional way. And so now we have a national cardiogenic shock initiative that's occurring. This is the group of Henry Ford people that are involved. Barbara Basir, who now is one of our faculty, is one of the co-principal investigators. Ruth Fisher with the administrative group, Mike Hackla and Tyrell, who are our coordinators, and TSCL, who's our data monitoring person. So we're able now to, with this small band of brothers, we're able to go around the country and tell people how to do it, basically. So people have rapidly accepted this approach, and now we have almost 70 hospitals around the country that are following the same kind of protocol. And we're rapidly collecting data. We have submitted it for major publication. We just completed recruitment of the 100th patient in this program last week. So we're going to rapidly accumulate data. This is as of 2 weeks ago, but now there are 100 patients that have been recruited. I just really want to basically show what the bottom line is, that we now have a 77% survival. So with this approach, we're dramatically expanding the survival for these patients, and it's something that I think we should all take a great deal of pride in. And again, Henry Ford is really leading the country in developing new treatments for this procedure. While we're doing this, and again, this is something that might be of interest to some of the physicians, we're really trying to come up with predictors for patients that might survive. Cardiac power output is a method of looking at the cardiac output of the heart, and lactates are looking as to whether or not the patients have tissue ischemia. And what we found is an interesting pattern. When the patients, we looked at the survivors and non-survivors, and the non-survivors have a continued production of lactate, meaning that they're continuing to have tissue ischemia and hypoperfusion, whereas the patients that survive very rapidly start clearing lactate. And so this clearance suggests that the tissue is getting adequately perfused, and the patients are basically going out of shock. The cardiac power output, very similar sorts of patterns. The survivors in blue, and you can see that the cardiac output within 12 hours starts to improve, and one is normal. So within 24 hours, the survivors have all kind of gotten out of cardiogenic shock. So this looks like it's going to be very, very prognostic. If you combine the two, if you have a patient that has a low lactate and a cardiac power that's normal, a 97% survival, and that can be predicted within 12 hours of onset of admission to the hospital. So we're going to be using these kind of parameters to really kind of define how we're going to be treating the patients. at 12 to 24 hours. If they're not clearing their lactates and their cardiac power is still low, we're going to be relying with our transplant VAD group to figure out if the patients need to have support escalated. So this is something, again, that's going to kind of indirectly impact the transplant group. But I think it really shows you that the power of doing these new kinds of procedures and improving the outcome for these patients. So we think that with mechanical circulatory support, if we get rapid access, if we measure hemodynamics, provide the patient with circulatory support, we can dramatically decrease the use of vasopressors and inotropes, and if necessary, we can escalate early. But with this approach, I think we're going to demonstrate that we can dramatically improve outcome for acute cardiogenic shock. Again, I've been doing research in this for 30 years, and this is the first time in 30 years that I've seen an improvement in this condition. So I think it's really a dramatic testament to the group here, the ability to really rapidly accumulate these patients and collect the data. And we'll be doing multiple randomized trials in this space. I think we are going to be leading the country in how we manage and how we treat and how we develop new techniques for the management of cardiogenic shock. I just want to conclude with you. I just want to conclude this afternoon by kind of showing you the approach. What we're looking at is trying to understand where the diseases of the future are going to be. Where is our population? What are the diseases of the future? And then try to develop new treatments for those patients. And as we develop new treatments, we have to be cold-bloodedly analytical about looking at our results. And so you do a treatment, you look at the results, and then you publish the results, and that's really comes the full cycle for how we really advance the care of our patients. Thanks very much for your attention.
Thanks a lot, Bill, for that really fascinating talk. I have a question to start with, and then we want to open it up for questions. Mine is not that medical, though, so I guess one thing your program has in common with a lot of ours from the Transplant Institute perspective is that we're trying to reach out and bring in patients and collaborate with doctors, referring doctors and others from all over. If you were going to give people advice or a couple of tips, what would be, so your number one or number 1, 2, 3 about how to do that, because you've done it very successfully and obviously have a huge network and grown a big program. What would you tell us for us that are trying to do that?
So I tell all the fellows that are working with me, in order to build a practice, you guys have all heard about the 3 A's. Okay, so number 1 is available. Okay. Number 2 is affable. And number 3 is able. And that's the order, okay? Available is number 1. And so just before I came down here, I got a call from Lansing for a patient that's really sick that needs to be transferred. And you just say yes, and you accept the patient, and you're very kind to the patients and kind to the referral doctors. So I think being available is really important. And then, the care and feeding of our referral doctors is absolutely essential. We know who's sending patients to us. We know who's not sending patients to us. If they're not, why not? What happened? Did we do something to upset them or their family? And I always tell the patient before they leave, I say, now you make sure you tell Dr. Jones that we took really good care of you. I say, okay, doc, they do. And so I think those are just sort of simple common sense, but I think that the care and feeding of the referral physician is absolutely essential. And it's really different than in kind of an institution where you show up, like in the cath lab, you show up and you've got 4 patients on your board. And well, how do those patients magically show up? It's not that way. If we're going to continue to be a major referral institution, it's just absolutely essential that you understand who the referral doctors are and make sure that they communicate. The 2 things that the referral doctors hate the most are, number 1, when they don't know what happened to their patient. So the patient comes back to see him in the clinic. I don't know if you've ever been in that circumstance. I sure have. I see the patient. I don't have any notes. Well, what did they do to you? What did they say? I mean, it's really embarrassing. And the second thing is that they hate it when the patient doesn't come back to them. And so those are the 2 things that the referral doctors hate. So communicating with them and making sure that the patient goes back to them. So what we try to do at discharge, we tell the patient, make sure that you make an appointment to see your doctor within a week. And that way we are sure that the patient goes back and sees them. So I think it's just sort of common sense, but it's really amazing how people just don't understand how to build a referral practice.
All right. Had one. Oh.
Hi, I'm Hari, one of the anesthesiology residents. This probably is, a very basic question, but is there any role for TAVRs in emergent situations? Recently, we had a patient who had severe aortic stenosis, who was going in for a hip fracture and was not able to tolerate the procedure because of aortic stenosis. Would there have been a role for doing a TAVR before going in for the procedure?
Yeah, that's a great question, actually. And if the patients have critical aortic stenosis with a valve area less than 0.7, it's really unlikely they're going to be able to augment their forward cardiac flow with any degree of vasopressor support. So that's kind of at a critical point. And what we do with those patients is we do a balloon aortic valvuloplasty. We can usually get the valve area up to around 0.9, which is enough to get them through their surgical procedure. And then they will recuperate from the surgical procedure and then have a TAVR done electively. Again, we have reporting and public reporting, and it's really very difficult in some of these patients to know whether they're going to survive or not. The one place where true emergencies are done, and we've done true emergencies in patients that have bioprosthetic surgical valves that are starting to severely malfunction. In those patients, when the leaflets of the bioprosthetic valve starts to malfunction, they rapidly deteriorate, and they can die within 24 hours. So in those patients, we have done emergency TAVRs, but that's really the only circumstance. Otherwise, we try to bridge them. If it's native aortic stenosis, we try to bridge them with a balloon valvuloplasty. And we still do about 100 balloon valvuloplasties a year here in our program, again, to try to optimize the patients before they have the TAVR procedure performed.
All right, well, thank you very much. Thank you all for coming.